keep the questions until the end.
Good morning, everybody. I'd like to share with you about the maximizing the impact of the ART therapy to the end epidemic of Vietnam. As you know, so far the population in Vietnam is 87 million. The HIV population in 2012 is about 257,000 cases estimated. HIV prevalence is 0.46% in the age of 15 to 49, and people living with in that drug in 11.6%, and female sex worker in the 2.7%. So far, the epidemic in Vietnam is still concentrated epidemic, and mainly for the inject drug use. And we have response to the HIV activity and for the harm reductions in ART scale up. Up to now, we have 72,000 cases enrolled ART, and coverage on eligible about 60%. But so far we have some challenges. And the first is the limited HIV testing coverage in the key populations. There are only 31% people living with inject drug have consent with access to the testing in the 12 months. 40% is the MSM, and 40% of the female sex workers, their coverage in the past 12 months. And second, in the late ART initiative treatment, nearly half of the ART with the CD4 count is less than 100%. And lost follow-up after the diagnosis, and 80% of the funded by the external donor for the treatment and care. In my presentation, I've focused on the sub-issue, the mathematical modeling and test and treat initiative in Vietnam, and innovations in service delivery. The first is the mathematical modeling study is to carry out in 2012 to understand the potential impact of the ART, the expansion scenario in Vietnam. We carry out in the Cần Thơ province, and for the new infections from 2012 to 2015. The study intervention, annual voluntary testing, and immediately ART. For the immediate ART provide a single group population. You can see about the new infection from 2012 to 2015 for the single group, the population, the people living with inject drug in female sex worker and MSM and males client with sex worker and low risk worker. For the both sides in the project costing the same group. This study may have result about the prioritize key population, especially the people living in that drug for early ART assess at least to list new infection with the list code from 2012 to 2015. We have the article published in the Lancet paper about the key finding about the periodic VCT immediate ART in the potential for the market reduction in the new infection in age. an effective strategy and prioritize the key population for the early access and combined with the other intervention and syringe, methadone and condom, and leading to the cost saving in around 20 years later. And second, the activity in immediate ART test and treat initiative in Vietnam to translate incident into the program. The first is the serologic couple. We carry out in the Viet Minh and Can Tho province from the March and December 2013. We follow up the 12 months for each couple, and the outcome of study in the virus suppression cascade, risk behavior, partner seroconvergence. So far, we have the 134 serologic couple identified, and the people starting ARV with high CD4 count achieve a similar level of the virus expression to those starting with the low CD4 count. After the month 3, the more detailed study will be presented by Dr. Nguyễn Thị Thúy Vân on day 4. The people who inject drug, the MS, they assess the feasibility and acceptability of the various voluntaries. We carry out twice a year and immediate HIT among the HIV people. Carried out in Thái Nguyên, Thanh Hóa province. We already enrolled from the last yesterday. That means from the 2nd April 2014. And next activity for the test and treat in the mountainous province. We carry out in the 16 mountainous province and select the regions. To assess the CD4 count, not easy in the mountainous province and the prison. At a delay and miss the opportunity for the timely ART initiative. We start from June to 2014. And other activities, innovation in service delivery, treatment 2.0 and MTMCT to integrate the HIV service to primary health care for the effects, sustainable program. The first is we carry out the pilots treatment 2.0 initiative in 2 provinces, in Can Tho and Điện Biên, and promote early diagnosis and treatment to enhance the ART benefit, especially for the key populations. And so far, we already integrated HIV testing and IT follow-up into the primary health care service, point of care CD4 counts, and engaging community partner in 4 provinces. And interim result and expanded access to HIV testing in the remote area and key population, and leading to earlier HIV treatment initiation and accessibility for HIV service delivery at primary health care sites. As you know, it start initiative CD4 count before the treatment 2.0 and during the carry out the treatment 2.0. You can see most people started the treatment in the commune. That means during the treatment 2.0 pilots, we almost more than 2050 CD4 counts. Pregnant women, we already carry out for the 6 province. And from the March of 2014, for the 6 province, integrate the HIV testing into the routine antenatal care packet and immediately ART for the HIV pregnancy woman. Summarize. And Vietnam has a planned effective IIT programming through the mathematical modeling and implementation study and service delivery pilots, and the design of the informal national policy to maximize HIV transmission and deaths, which IIT be one of cost component of the national response. And in Vietnam, I am to move step by step for towards and to end HIV epidemics. Last slide, we would like to thank staff in the Ministry of Health and other organizations already support for this study. Thank you very much for your attention.